So welcome. For those who haven't met us before, my name is Anita Panayiotou. I'm a clinical neuropsychologist and I'm part of the team at Thrive Aged Care Consultants. I'm really passionate about improving outcomes for older people through early recognition, evidence-based care and person-centered approaches. And delirium is a common but often preventable and treatable condition, and the way we recognise and respond to it can have a significant impact on a person's health outcomes and quality of life. So I'm really looking forward to exploring this topic with you today. In the photo, you'll see the two directors at Thrive. We have Kate Lamont, occupational therapist, and Kathy Kirby, registered nurse, and they are both here online today, and I think they're trying to give you a bit of a wave. So at Thrive, we're a team of experienced clinicians and consultants supporting residential, community, aged care and health services. And we provide practical education, mentoring, quality improvement and consultancy services to help organisations strengthen workforce capability, improve outcomes and navigate ongoing reform with confidence. So if we can be of help with anything, please reach out for a chat. Just a little housekeeping before we launch in. Please keep yourselves on mute and make good use of the chat function. So Kate and Kathy will be monitoring it, and there'll be time at the end for questions. So we're going to be recording this session, but we'll pause the recording at the end so you can ask your questions freely. The recording will be uploaded to YouTube. You're free to use this for your own training with your teams. Just don't forget to like and subscribe to the channel. And after today, you'll receive a copy of the slides in PDF format and a link to the recording. So today, what are we going to be talking about? We're going to be exploring what delirium actually is and why it should be considered a medical emergency. We're going to talk about the impact that it can have on older people, their families and healthcare services. We're going to talk about how delirium presents, the different subtypes, because it doesn't always look the same. And some forms are harder to miss than others. We're going to look at the factors that increase a person's risk of developing delirium. We'll talk through the common causes of delirium. And a key focus of today will be focused on evidence-based strategies that actually reduce the risk. And we're going to talk through and bring it all together with a case study at the end. So I'm hoping that by the end of the session, you'll feel much more confident in identifying, preventing and responding to delirium in your practice. So I'd love to hear from you in the chat. How often have you seen acute changes dismissed as a normal part of aging or a progression of dementia? So the person might suddenly seem more confused. They might suddenly be unable to pay attention. They might be unusually lethargic and sleepy or just not quite themselves. But how often are you seeing that these things are getting rationalized as, just a normal part of aging or as dementia, as I said? So I'd like to hear from you if you've got any comments you want to share there. But the research suggests it's happening very often. Around half of delirium cases are going unrecognised. So the rates of delirium that we're seeing in our clinical practice might make us think that it's not a common condition. But in fact, it's extremely common. In hospital settings, it affects 1 in 5 older adults, and it's closer to 4 in 5 in older adults in intensive care settings. In residential aged care, delirium rates vary considerably. I'll just get you to pop yourselves on mute. Can't be you. Thank you. In residential aged care settings, delirium rates vary considerably depending on the population being cared for and the clinical circumstances. So the estimates are ranging from about 1 in 10 residents through to 1 in 3 residents. And people living with dementia are particularly vulnerable with a 6 times the risk of experiencing delirium. So it's not rare. It's not just happening in exceptional circumstances. In older adults, it's one of the most common conditions, and we overlook it, especially those less obvious presentations. They're most vulnerable to being missed. So that's why we need to be thinking that any acute change from a person's usual functioning, whether they have dementia or not, that should prompt us to think delirium and to take appropriate action. So what is delirium? It's not a normal part of aging or dementia, but it's an acute change in a person's thinking, attention, awareness, or behaviour. And as I said, it should always prompt further action and assessment. It's a serious medical condition and it should be considered a medical emergency. But unfortunately, it is often missed or overlooked. It can be mistaken for normal aging or dementia or just general confusion. It's not a disease in its own right. So it's a clinical syndrome. And it's a collection of symptoms that can be caused by lots of different underlying medical problems. And some of the common causes include infection, medications, sudden illness, and we'll talk through a lot of those a little bit later. One of the defining features is that it develops rapidly. So unlike dementia, which typically progresses gradually over months or years, delirium develops over only hours to days. It's characterized by a disturbance in attention. People often have difficulty focusing and maintaining their concentration or following a conversation. They might appear easily distracted or unable to stay on track. There's also a change in awareness of the environment. The person might seem less connected to what's going on around them, appear confused about where they are or what's going on. And changes in cognition are also what characterises it. It might be that there are changes in a person's memory or language, or they might have trouble thinking things through and making decisions. Another important feature is that delirium fluctuates. The symptoms might be really noticeable at one point in the day and less obvious at another point. And so family members and carers, they might describe the person as just not being themselves that day or noticing that their confusion comes and goes. And this is something that makes it quite tricky to recognise. So as I said, it's common. It occurs in every setting, hospital, aged care and community settings. And so wherever we are caring for older people, there's a risk that delirium can develop. The good news is that delirium is often reversible, and when the underlying causes are identified and treated promptly, many people have a full recovery. However, any delays in recognising delirium and treating those underlying causes can lead to poorer outcomes. So we'll just have a look at that now. Delirium itself is not just a temporary episode of confusion. It's associated with significant harm and poorer long-term outcomes for patients, particularly when there's a delay, as I said, to recognising it or to treating the underlying cause. So compared to people the same age who do not develop delirium, those with delirium are at increased risk of falls, of other hospital-acquired complications, of longer hospital stays, and even death. It can have long-lasting effects, so people can have a loss of function and independence, and it makes it hard for people to return to their previous level of functioning. And some people continue to experience cognitive difficulties even after that acute confusional episode has resolved. And so for older adults, this is really important because delirium can be a turning point in their lives because it increases the likelihood of them needing additional support. Perhaps after hospital discharge, they may never get back to where they were, and it might actually prompt an admission to residential aged care. So there's a greater risk of that too. So that's why it's a medical emergency. It really requires immediate attention. It's a serious patient safety issue, and early recognition, investigation, and management can reduce that harm and improve outcomes for patients and their families. As I mentioned, it can be tricky to recognise, and that's because it doesn't always look the same. There are three types of delirium. There's the hyperactive delirium, the hypoactive delirium, and a mixed delirium. So in hyperactive delirium, this is where a person is very restless and agitated. They can be more physically active than usual. They might appear to be unable to settle. They might frequently try to get out of bed or out of a chair. They might pace up and down and wander and repeatedly call out. They might appear irritable, they might have mood swings. They can also become uncooperative with care or resistant to assistance, particularly if they're confused about what's going on around them. Hallucinations and delusions are also something that can happen in this type. So the person might report seeing things that are not present, like people or animals, or they might hold false beliefs and believe that staff are trying to hurt them, for example. So it's quite a disruptive condition, and it does go, it's very noticeable in a care environment. But hypoactive delirium is the subtype that's most likely to be missed. So unlike hyperactive delirium, where it's really going to draw attention, people with hypoactive delirium are often quiet and withdrawn and less engaged with their surroundings. They're not disruptive. Staff might assume that they're just tired or depressed or experiencing a progression of their dementia. And so people with hypoactive delirium, they typically look very drowsy and lethargic. They can spend more time sleeping. They might appear to show little interest in activities or interactions that they would normally enjoy. You'll notice things like slowed responses to questions, delayed processing, and reduced verbal communication. So the person might speak less, they might move less, they might appear generally disengaged from what's going on around them. So the family members and staff might just say that they are not themselves, they're flat, or they're just not interested in anything today. So these are the things to look out for. It's actually the most common type of delirium. And despite this, as I said, it's frequently under-recognised because it doesn't create the concern and the attention the same way that aggression or agitation might in the hyperactive state. And then the mixed subtype is characterised by having symptoms of both of these types of delirium or fluctuating between the two within the same day. So we've talked about what delirium is and why it's important. The next step really is to understanding who's most at risk. So there are many different risk factors for delirium, and it's often not one factor alone that's going to lead to delirium developing, but rather risk accumulates. And so we group these risk factors into two categories. There's predisposing factors, and they are the characteristics of the person that increase their underlying vulnerability. And then there are precipitating factors, which are those acute triggers that can then push that vulnerable person into developing delirium. And the more vulnerable the person is, the smaller that trigger needs to be to really tip the scales towards delirium. So, predisposing factors, they're the factors that make the person more vulnerable. They don't directly cause delirium, but they make the brain less resilient to triggers and stressors. And so some of these things include advanced age, pre-existing cognitive impairment or dementia, a previous episode of delirium, sensory impairment, poor vision and hearing, or uncorrected. And there are other important risk factors like depression, multiple comorbidities, polypharmacy, and use of alcohol or benzodiazepines. And so these factors are often cumulative, and a person may have several of these risk factors at the same time, and that can considerably increase their overall vulnerability. So let's turn to precipitating factors now, or sometimes called triggers or insults. And so unlike the predisposing factors, which are often long-standing and not easily changed, the precipitating factors are usually these acute events or stressors that can occur suddenly. And so common examples of things like infections, use of urinary catheters, changes to medication, a completely new environment, or even the bed move can be enough, poorly controlled pain, surgery or anesthesia, sleep deprivation, which happens very often in a hospital environment, dehydration, malnutrition. So these triggers, what's important to know is that they don't affect everyone equally. And so whether delirium develops is dependent on the trigger and the person's underlying vulnerability. So it's that interaction between the two. So if a person is relatively a fit older person, they might need a really major stressor, like a severe infection or major surgery before delirium occurs. But someone with lots of these predisposing risk factors really only needs a small trigger like even just a medication change or a poor night's sleep, and that could be enough to trigger delirium. So if we know that a person is particularly vulnerable, we can actually be proactive and we can try to avoid some of these triggers because 30 to 40% of delirium cases can be prevented. So I mentioned delirium is not a condition in its own right. It's a symptom of an underlying problem or several problems occurring at the same time. And so a structured approach like this one can help us so we don't overlook those common causes. So this is one of the most widely used frameworks. It's really simple. It's Pinch Me is the acronym that I hope you'll remember now. And it was developed by the British Geriatric Society. And so it's a really simple checklist of the common causes of delirium. And we should be considering these whenever a person suddenly changes from their usual baseline. So let's work through each one. So there's pain. So unrecognized or poorly controlled pain can contribute significantly. And that's particularly important in people who can't tell us that they're experiencing pain and discomfort. So we have to be on top of that. I stands for infection, which are very common as well. Things like urinary tract infections, pneumonia, very common triggers and causes of delirium. Nutrition is next. So poor nutritional intake, low blood glucose levels, nutritional deficiencies, they can also contribute. Constipation is another, so that's often overlooked, but it's a significant contributor, and especially in older people and those with reduced mobility. Hydration is another one. We can certainly be monitoring and supporting fluid intake, so that's important. Medication is next. So when there's new medications, if there's a change in the dosage of medications, if a person already is prescribed multiple medications, then we need to be careful of those interaction effects and any side effects as well. They can all contribute to delirium. And finally, the environment. So an unfamiliar environment, if there's excessive noise, if it's disrupting the person's sleep, if there's poor lighting and it's contributing to their sensory impairment, all of these things can contribute to delirium as well. So, yeah, it's really important to remember that many people will have more than one of these pinch me factors contributing to their delirium. And our goal is to work through it systematically to really try and identify as many of these contributing factors as possible and to begin treatment and mitigations as quickly as we can. The interesting thing here is that the treatment is also the same as prevention for delirium. So we can actually also use this acronym to help us be proactive as well, not just wait for when someone experiences the changes. So the research suggests that up to 30 to 40% of delirium episodes can be prevented through early identification of risk and consistent application of prevention strategies. So I'd like you to tell me in the chat, like if 30 to 40% of delirium is preventable, why are we still waiting for it to happen? So I'd like you to give me some ideas about why are we doing this? Think about the people you care for and how often are we looking for those predisposing risk factors like dementia and cognitive impairment and sensory impairment and advanced age? Are we routinely identifying the people that are vulnerable before it develops? And then once those people have been identified, what are we doing about it? Are we actively avoiding those precipitating factors? Are we putting in place prevention strategies as soon as we're identifying risk? Or are we waiting and only responding after a person becomes confused and agitated and withdrawn and distressed? So as I said, delirium is that interaction between vulnerability and triggers. And while we can't change the predisposing factors, we can definitely change the triggers, the precipitating factors before delirium develops. So yeah, I'd like you to reflect on your own area of practice and have a think about when you identify a person that's at risk, are you consistently putting in place prevention strategies or are there opportunities to intervene a little bit earlier? I might just pause here for a second to check in with Kate and Kathy. Are there anything in the chat that you want to let me know? Please feel free to jump in.
Excuse me, sorry. Some great answers here, Anita. Lack of staff training and education. So, confusing dementia and other conditions for delirium, which is why we're here today, covering this important topic. Not knowing how to identify delirium, as you were saying, that reactive rather than proactive mindset. Let's talk about resources as well. Talking about pain management in particular. And really around awareness. So, not identifying people who are likely to develop delirium, which I think is a really good point that you've raised today as well.
They're all so important. And yeah, definitely. So let's talk through now some really 6 proven strategies that can help us move from recognizing risk to doing something proactive. So these are 6 evidence-based strategies. They can help us prevent delirium in older adults. Then it's not rocket science, it's things we're doing every day. But the key thing is that we need to do them consistently for all of our patients and residents that are at risk. So we'll work around the wheel here, and feel free to use this and print it out and put it up in your settings. We can stimulate the person's mind. We can promote socialization and cognitive stimulation. We can promote mobility where it's safe to do so. We need to be supporting sleep, optimizing their vision and hearing, maintaining hydration, and ensuring adequate nutrition. So these strategies, they target many of those precipitating factors, the triggers, and also the pinch me causes that we discussed earlier. So yeah, I want you to think about which ones you're doing well consistently and which ones you're not doing consistently for all of those high risk individuals, and if there are opportunities for improvement. So yeah, it'd be great for you to be reflecting on that as we go through. We really need to, first and foremost, be involving families and carers, both in the prevention of delirium, but also in the management of it. So we can be forewarning families so that they can come with a sense of agency in preventing delirium too. So we can let them know what to look for. They can tell us when there are subtle signs that the person's changed from their usual baseline. So we can also recognize and respond to it quickly. We can involve the family in the person's care. We should be encouraging the families to visit as much as possible, to help orient the person to where they are, what's going on for the day, provide that reassurance, to bring familiar objects to help the person feel at ease, especially if it's an unfamiliar environment. You know, they might want to help by bringing the person's favorite pillow, and maybe that'll help them get a better night's sleep. Maybe it will be bringing in photographs, you know, to help them feel more at ease in a new environment. Whatever it is, these are really important strategies. The families also are really great because they can partner with us. They can help tell us what's usual for the person, what isn't, what are their routines and preferences, and as much as we can, try and stick to those usual routines that will help the individual as well. The environment is something that we can optimize as well to prevent delirium. It's not just after we identify confusion, because it certainly helps afterwards, but we can do things to prevent it. We can be supporting the person's orientation through clocks and calendars and orientation boards and even newspapers, you know, so that we're telling people where they are, what day it is, the season, what's happening for the day. They are really effective. Clear signage is really important, especially in these unfamiliar environments. So signs for things like the toilets and dining areas and other locations really help to minimise the confusion and improve the person's independence. We want to be trying to reduce noise as much as possible and that overstimulation. We know hospital wards and aged care facilities are really, really noisy and environments. So yeah, we want to try and promote sleep as much as possible. Sleep-wake cycles too with lighting is really important, natural daylight, and keeping things quiet and dark in the evenings. And as I said, trying to maintain familiarity and routine are really important as well. Okay, so let's talk through a case. This is Margaret. She's an 84-year-old woman admitted to hospital with worsening shortness of breath. fatigue, ankle swelling due to an exacerbation of heart failure. She normally lives independently at home and receives regular support from her daughter. Her medical history includes mild cognitive impairment, hearing impairment, heart failure, and osteoarthritis. So, have a think about what are the predisposing risk factors for delirium that you can identify here that make Margaret more vulnerable. So feel free to pop them in the chat. But I'm sure that you can pick up on them now that we've raised them. So it's things like older age, mild cognitive impairment, hearing impairment, and the multiple chronic health conditions. So Margaret is admitted to the medical ward and treatment is commenced. In her first day, she's in an unfamiliar environment. She's spending most of her time in bed because she's very fatigued. She becomes mildly dehydrated and she left her hearing aids at home. She's had a poor night's sleep and she's eating very little because she does not feel hungry. So I'm hoping you can identify the triggers at this point as well. So things like dehydration, reduced mobility, sleep disturbance. So let's consider two possible outcomes, our sliding doors moment, if you will. So in scenario A, we're going to fast forward 48 hours. Preventative strategies were not implemented consistently. Margaret remains largely bedbound. She's eating and drinking poorly, and she has another night of disrupted sleep. So now she has delirium. She's confused, she's unable to maintain her attention, she's disoriented, and she's very different from her usual self. Her length of stay needs to be increased because they can't discharge her with delirium, and she also develops an infection and a pressure injury as a complication of care. Scenario B, on the other hand, is what we're hoping to achieve. This is where Margaret is identified as being at high risk of delirium. And so prevention strategies were put in place and she is able to recover and remain cognitively stable. So the question here is, what are the preventative strategies that could have been implemented so that scenario B is where is the outcome? And so if we think through the possible causes, those triggers, what we want to be doing is encouraging mobility, optimizing her hydration, promoting nutrition, making sure her hearing aids are available, supporting her orientation, involving the family and trying to help her to get a good night's sleep, and maybe even stimulating her cognition as well through some meaningful conversation. So let's wrap things up. I want to bring it together with a few key messages just to say that delirium is a medical emergency. It can present as either hyperactive, hypoactive, or mixed. The hypoactive delirium is the most common subtype, but that's the one that's frequently missed. And so really we need to be thinking delirium whenever there is a change, acute change from the person's baseline. That's going to prompt us to be thinking delirium and to take action. It causes significant harm, so the longer that we wait to recognise it, the more harm that it can cause as well. We want to be identifying it early and even preventing it. So it occurs when it's that interaction between vulnerability and triggers, so we can prevent it by addressing those triggers. We can partner with families who are valuable partners in care. They can help with that prevention and the management. And as I said, proactive strategies is really what we want to shift to prevent delirium altogether, but then if it does occur, to support quick recovery. So if we reflect back on Margaret's case, I'd like you to think, or you can write in the chat, think about your own workplace and where you see the greatest opportunity to prevent delirium could be, and one thing that you might do differently tomorrow to reduce the risk of delirium. So feel free to write in the chat. Okay, that takes us to the end now. So if you're keen to learn more about delirium, we have a comprehensive online program on the Open Learning platform. It's facilitated and developed by me, and there are short modules that you can work through at your own pace. We can also deliver training in person or online via a live session. So if you'd like more information about that, please reach out to Kathy. Her email is there. And we would really value your feedback. So if you wouldn't mind taking a few minutes to complete this survey, it's completely anonymous and there's only 4 questions, and we really value that. So I'll just give you a second to grab that QR code. And so what we'll do now is we're going to pause the recording and we'll take a moment for any questions, and we'll review what's come up in the chat. So thank you so much for your time now.